Doctorate in naturopathic medicine from National University of Naturopathic Medicine in Portland, Oregon. She took a postdoctorate position in Atlanta, Georgia, with a nutritional laboratory company called Metamatrix, which has since become or merged into Genova Diagnostics. She completed her residency at a medical clinic in Atlanta, and then she moved to the Northeast about a dozen years ago and is now the medical director of a both in-person and virtual practice located in Sandy Hook, Connecticut. She is also the director of the Functional Medicine Clinic Immersion Program for professionals transitioning into functional medicine. She has a podcast series, which I highly recommend, has an active blog on her website. She recently co-authored a book on an ebook called The Methylation Diet, and she is actively involved in research on using that dietary program. And with that, I will turn it over to Dr. Fitzgerald.
Thanks, Dan. I'm excited to be with you here today and talk to you about one of my favorite conversations, fatty acids. We're going to talk about polyunsaturated fatty acids today primarily and look at their involvement in the etiology of and treatment for chronic immune-mediated diseases. We'll go through sources, we'll talk about supplements, and then I'll describe the prescription for various inflammatory conditions. So what if you had a drug that would allow you to reduce your risk of cognitive decline by 50%, or reduce your risk of dying from sudden cardiac death by 30%, or was as effective as Humira for relief of pain associated with rheumatoid arthritis? You would put this drug in the water, wouldn't you? Fortunately for us, it is. Of course, I'm talking about EPA and DHA coming from fish, and we will dive into the wonderments of the science behind it. However, no discussion is complete if we don't touch upon some of the research and some of the description of omega-3 research in the news. You likely saw the MedPage Today write-up or something similar challenging the findings of the recent Reduce It trial, challenging actually the placebos being used. I think it's worthy dialogue, but I think the Reduce It findings are strong enough to stand on their own. Wall Street Journal was out recently too with the fraud of fish oil. He's hoping kale will be next and beets right after that. I don't think he's got a strong case, but there it is. And of course, there's always different meta-analyses coming, pushing against any support for omega-3s. However, one of the challenges, a fundamental challenge, I think, of the body of research established, especially some of the newer trials, is that they use a primary endpoint that's a composite. So everything that they want to look at is bundled together. In the VITAL study, they're looking at cardiovascular diseases and they're looking at cancer, and it's all bundled together. And if it's not collectively significant, then the trial is dismissed as not showing benefit. And that was the conclusion in this VITAL study that was published in 2019. Specifically, they said that The VITAL trial showed that supplementation with either an omega-3 fatty acid at a dose of 1 gram a day or vitamin D3 at a dose of 2,000 IU a day was not effective for primary prevention of cardiovascular disease or cancer events among healthy middle-aged men and women over 5 years follow-up. However, if you tease out the composite, and I would argue that we always need to do that, and you look at this secondary analysis, you really see some pretty interesting things. So related to just EPA and DHA, and I want to point out that there's only 840 milligrams used of EPA and DHA total, they found a 28% reduction in reduced risk of heart attacks. And my italicized point here is 77% reduction in African Americans specifically. Now, if that doesn't scream follow-up, we need to get to the bottom of that statistic and confirm it. 50% reduced risk for fatal heart attacks and a 17% reduced risk for total coronary heart disease events. These are impressive findings and worthy of note in the VITAL trial. And again, this is one of the only prevention trials. They're looking at healthy people preventing these events. You might be familiar with the ASCEND trial, similar conclusion that in the composite, primary endpoint, their benefit was not noted. But again, when you do a drill down, when you tease out that primary endpoint, they found a significant benefit with cardiovascular disease death. It was reduced by 19%, again, using the same EPA-DHA formula of a mere 840 milligrams per day. And this population were diabetics. Now, recently, the Reduce It trial has gained a lot of attention. It brought omega-3s onto the map, actually specifically EPA. It was an EPA alone formulation. And yes, as I said earlier, there was some challenge for the using mineral oil as the placebo, and I think that's fairly argued, but I think the findings really speak for themselves. There was a 30% relative risk reduction in total cardiovascular events with 4 grams a day of EPA in patients with hypertriglyceridemia. What do I want to say about this? It was a large study. I think it was overall a well-conducted study. There were some limits to the Reduce It in that it was primarily white men. These folks were older. They were polypharmacy on anticoagulant therapy, statin therapy, antihypertensives. So they were on the cardiometabolic continuum. Looking at some of the biomarker changes, you can look at this later, or you can pull up the full text. You'll see that there's just some nice shifts with this intervention. Now, right on the heels of the Reduce It, and again, the Reduce It used, so one of the main criticisms that we've had in functional medicine against some of the studies is that they're not using an aggressive enough intervention. They're not using the dosing that we would use. So we were waiting with bated breath for the findings in the Reduce It, and I'm excited about those. And also the strength trial. Both of these studies used 4 grams. The Reduce It was just EPA, and in the strength trial, it was 4 grams of an EPA DHA carboxylic acid, which is just a free fatty acid form. So we were excited to see these and tease through them. I think the Reduce It findings are solid. The strength findings, however, they stopped the study at 3 years because they weren't noticing any benefit. Unfortunately, I think that's that they're remiss. I would have liked to see the trial continue. When you dig into the data, we do see that there was a 15% reduction in coronary events in patients with established cardiovascular disease. There was a reduction in CRP and triglycerides, a modest increase in HDL. Dr. Bill Harris, arguably the world's expert in omega-3 fatty acids, also suggested that the trial duration was inadequate to really turn things around. And he also challenged data analysis. So his thinking was, if we look at the red blood cell concentration of EPA and DHA, something he's termed the omega-3 index, and I'll talk about this more later. If you actually look at that and look at differences in outcome between those in the lowest and the highest quintiles or quartiles, we might also see some significant information there. So I think that the strength trial data will hopefully get teased out a little bit more, and we will learn more from this important study. Of note, no increased risk of bleeding in any. So in the strength trial and the reduce it, now those first two trials, the majority of the individuals were on multiple medications, including anticoagulant therapy. So I think this is an important point. And they were older. The OMEMI study also looking at older population post-MI, no increased risk of bleeding there. VITAL, ASCEND, and JELIS, again, no increased risk of bleeding. I think it's time that we can put this concern to bed. So while we didn't see an increased risk in bleeding, which I think is important, we did see a slight increased risk in AFib and flutter. This was noticed in the strength trial. It did achieve significance. The reduce it trial only showed a trend. It didn't achieve significance. OMEMI did achieve significance. No noted increased risk for AFib in ASCEND or VITAL. So we've got to pay attention to this. We've got to tease it out. We have to understand, how to think this through in our own patient populations. So my read on the literature suggests that vulnerable folks are those that were in these studies. So that is older individuals with a history of cardiometabolic disease and cardiovascular disease, on polypharmacy, most of them on anticoagulant therapy, antihypertensives, cholesterol statin therapy, and other medications. So that seems to be the vulnerable population. There's also some research to demonstrate, and I'll show that slide a little bit later, that it's in fact a U-curve distribution. So people who are the most deficient and people who perhaps hit up above to an excessive level are at risk. So I think we could, this is our vulnerable population, and maybe the 4 grams used in these studies kind of put a certain subgroup, a slight subgroup at increased risk. I put a link to a reading or a citation for a reading down at the bottom of this slide. If you want to look at additional, it's a good review. It's published in 2016, so it doesn't include the strength or the reduce it. But if you look at the data prior to these studies, you'll see that omega-3s are considered as an intervention for AFib. In fact, some of you are probably using it. And I think in those that are insufficient, increasing omega-3s is actually indicated for AFib. It's not always effective, but in this 2016 study, you didn't see really any negative outcome or very few studies that suggested negative outcome. So deficiency and excess are in a vulnerable population are probably how we want to think about addressing AFib. Takeaways, to me, it's a no-brainer. EPA and DHA is still appropriate prescription in our population and in cardiovascular disease specifically. We want to tease out secondary endpoints to make the decision on the utility of EPA and DHA in the research. There's an slight but significant increased risk in AFib in a vulnerable population, no increased risk for bleeding, even on anticoagulant therapy. EPA alone might yield more benefit in cardiovascular patients, that as they used in the Reduce It study, and it might be a little bit safer in those we're concerned about AFib with. Not all EPA and DHA preparations are equally bioavailable or physiologically beneficial. Perhaps that's the difference between the strength and the Reduce It trials. But in general, fundamentally, I think EPA and DHA are beneficial. Going beyond cardiovascular disease, however, those are important to touch upon, and I start with them every year because there's always some new and exciting studies coming out. We want to drill down into the omega-3 and the omega-6 family and see what they're about and how they're influencing, chronic diseases that we're dealing with in practice, and inflammatory-driven chronic diseases. There's much more to both of these families. So you can see on the left-hand side, this is the omega-3 family of polyunsaturated fatty acids. On the right, the omega-6s. We'll talk about the enzymes, those blue diamonds in the middle, food sources, the extensive collection of important derivative compounds produced by both families, and how they are important to have some kind of an idea about in inflammatory conditions. An extremely important exercise in the practice of functional medicine, which is the clinical application of systems medicine, is thinking about not just your patient's clinical imbalances in the context of the matrix, but also how the interventions that you're going to prescribe will impact the matrix and where they fit within the matrix. So defense and repair, the module we're obviously focused on here, is fundamentally where, we sort of house inflammation. And when we look in the chronic diseases that we're addressing, fundamental to those is inflammation. So inflammation informs all of the nodes in the matrix as related to our clinical imbalances. And a significant mediator of inflammation is imbalance in our fatty acids. So an imbalance in omega-3s relative to the omega-6, and an imbalance in the derivative molecules of omega-6 produced relative to omega-3. So fundamental to quenching inflammation and really impacting the entire matrix itself and your patient's well-being is balancing fatty acids. We're still deficient in our intake of omega-3 fatty acids, despite the fact that it is really, depending on where you're looking, the #1 supplement ingested, and certainly in the US. It's a top 10 supplement for sure. We're still deficient. We're still not ingesting enough. Average intake is under 100 milligrams per day. And heart failure patients are even lower. So arguably the patients requiring, or the people requiring fatty acid balance the most, are those that are ingesting the least. We evolved, ingesting a 1-to-1 ratio of omega-3s and omega-6s. In fact, foods that we evolved on had a higher amount of omega-3. So there was a balance between these two. Once we moved into modern era where foods are processed, we leaned heavily into omega-6s, profoundly skewing the ratio. Now it's up to maybe 25-to-1 omega-6 to 3 intake. And even, the NIH is recommending a daily recommended intake of 11-to-1 omega-6s to omega-3s. So it's a profound imbalance. It's a massive, unintentional, non-placebo controlled experiment in omega-3 deficiency, and the results don't seem to be good. As I said, inflammation plays a role in most conditions. In fact, all, I would argue, but to be conservative, we'll say most. Diabetes, Alzheimer's, cancer, arthritis, colitis, eczema. And when we look at conditions amenable to treatment with essential fatty acids, it's broad and deep. So allergy, eczema, asthma, autoimmunity, cardiovascular disease, chronic kidney disease, neurodegenerative diseases, neurodevelopment diseases actually, such as autism, could be on this list, mood disorders, dysmenorrhea, cancer, cachexia. In fact, this is a pretty neat 2017 study looking at early supplementation of DHA in those ApoE carriers may decrease risk of Alzheimer's disease, but it has to be started prior to symptom onset. DHA comprises 50% of the polyunsaturated fatty acids in the cell membranes in the central nervous system, DHA. It's critically important in Alzheimer's disease, in any neurological condition. It's one of the reasons why that REDUCE-IT study using just EPA prompts me to pause. I think for my patients, I'd like to see both EPA and DHA because DHA is so fundamentally important. But in a vulnerable population where I'm concerned about AFib, I might consider EPA alone And because it can be converted to DHA, perhaps pay closer attention to lab results. But, you know, in general, I think we want to be appreciating the importance of DHA and making sure we're getting sufficient amounts in our patients, particularly in somebody who's vulnerable to Alzheimer's. Here's the prescription that we recommend. Alpha-linolenic, the first and essential omega-3, truly essential omega-3. We can't make it in our body. We recommend it as ground flax, and as I'll show you later on, ground flax seed itself, as opposed to the isolated oil, has a bunch of really beneficial added constituents, not just the fiber, but compounds called lignans. They're very robust in. So ground flax, maybe up to 2 tablespoons a day, providing about 5 grams of alpha-linolenic acid. EPA and DHA, reading the literature for inflammatory conditions, up to 6 grams per day. More than 7 didn't show benefit. There are some exceptions to this. Less than 1.5, not effective for classic autoimmune conditions and other inflammatory conditions. In looking at the cardiovascular disease, 1 to 4 grams has been shown to be beneficial, as I just walked through, and EPA in certain situations may be considered alone. When you're purchasing EPA and DHA, often you'll find it in about 1 to 5 to 1 ratio. EPA is higher. For vegetarians, you're going to, if vegetarians who are not willing to take any fish oil, we need to be paying attention. You'll need to lean on, if you're directly addressing an inflammatory condition and you're trying to achieve the levels that I just recommended, you're going to have to lean on algae. There are a few newer brands out there that do have some EPA. You're going to have to go fairly aggressively with those, although it's pricey. Additionally, you'll be using flax oil, because you'll need to get to higher amounts, much higher amounts than you could with seeds. You'd be ingesting so many seeds to be able to sufficiently convert the ALA to EPA. So algae will be used, ALA as oil would be indicated. You could use a collection of different seeds, so chia, flax, nuts like walnuts could be effective. Bottom line is that you want to monitor this via lab to make sure your vegetarian patients are achieving the therapeutic goals that you've established. And I do want to add that DHA does retroconvert to EPA. So DHA has more carbons. It's a longer fatty acid than EPA, but we're able to actually retroconvert it back to EPA. So that's one way that algae, which is predominantly DHA, will help increase EPA. Gamma-linolenic acid, so this is our anti-inflammatory omega-6. Research suggests that up to 3 grams per day can be helpful. You always need to take gamma-linolenic acid with the omega-3 EPA, not a lot. It doesn't require a lot of EPA to inhibit GLA's conversion to AA, but you need to take it with EPA. Otherwise, gamma-linolenic acid, as I'll show you in a second, will convert to the very pro-inflammatory arachidonic acid. And evening primrose is a source that I use in practice commonly. Borage is a good one. Blackcurrant also has a decent amount of GLA in it. So here it is. Converting, so the precursor fatty acids will convert to arachidonic acid, looking on the right-hand side of this chart at the omega-6 pathway. When you provide EPA, eicosapentaenoic acid, that inhibits delta-6 desaturase and therefore inhibits conversion of GLA to arachidonic acid. Another way we can favorably shift our patients' omega-6-3 ratio is with diet. If we move out processed food, we're going to be dropping omega-6s considerably right there because that's where most of them live. And, you know, we evolved with a 1-to-1 ratio, omega-6s to 3s. And while we don't need to go that low, you can see here that, you know, a ratio of at least 5-to-1 omega-6s to 3 exerts an anti-inflammatory effect. Again, the NIH's daily recommended intake of 11-to-1 is probably too high and may promote inflammation. So we want to increase our blood cell omega-3 quantity. We can do that most readily by supplementing with EPA and DHA, reducing omega-6 intake in the diet. Now we know that we can compete, we can engage in desaturase and elongase competition by providing alpha-linolenic acid and eicosapentaenoic acid. So that will inhibit production of arachidonic acid from the other omega-6s. We can reduce upregulation of the enzymes involved in fatty acid synthesis by, again, supplementing with EPA and DHA. This is how that potent hypotriglyceridemic effect is exerted. So supplementing with EPA and DHA will drop production of desaturase, elongase, and fatty acid synthase down. Also, lowering insulin and glucose itself will inhibit increased production of these enzymes, genetic upregulation of these enzymes. Reducing alcohol intake, avoiding glucocorticoids as possible, all will help reduce the omega-6-3 ratio. All right, focusing on omega-3s there, we're starting with, you can see alpha-linolenic acid up there on the top, the food sources, just glancing down the omega-3 side, we can see food sources for DHA, for EPA, and then on the right-hand side, of course, we can inhibit production of arachidonic acid by providing EPA. We improve this via supplementation, via changing the 6-3 ratio in our diet, reducing insulin, reducing glucose, reducing alcohol and corticosteroid use. The total omega prescription should include GLA, alpha-linolenic acid, DHA, and EPA. Taken together will reduce the production of arachidonic acid, will inhibit the enzymes of the arachidonic acid cascade, will also stimulate the all-important derivative, anti-inflammatory derivative compounds that I'll talk about called resolvins. When we engage in monotherapy with any of these, we run the risk of imbalance, and we can ensure that our patients are balanced by testing. Actually, I'll talk a little bit more about it, but testing is really quite readily available these days. Our goal remains, I've been delivering this lecture now for 11 years, and our goal continues to be moving balance away from omega-6 and arachidonic acid. Now, that said, I want to point out the fact that arachidonic acid derived eicosanoids, so these molecules produced by arachidonic acid, I'm going to jump in a moment, are essential for generating a normal immune response. However, arachidonic acid is what we call a big 5 fatty acid. We've got lots of it in the body, and generally speaking, there's an imbalance between 6 and 3. Additionally, so not only do we need it to fight inflammation, and most of us have plenty to be able to make those derivative molecules, arachidonic acid derived lipoxin, which is in that resolvin family that I'll talk about in a little bit, is an essential first step in inflammation resolution. So we do need arachidonic acid, but not too much. I just want to use myself here as an example. This was me. Here are my omega-6s. I get a big fatty acid panel on myself, actually, and I do a comprehensive laboratory analysis, annually. I think it's pretty helpful in guiding my nutrition intake. And in 2018, you can see up there in the top, I had developed a habit of eating a particular mayonnaise that was delicious. It was organic, but it didn't have the right ratio of fatty acids. And I was really quite surprised. I think I had 1 jar of this. When I got my testing, it coincided with this particular mayonnaise phase of mine. My arachidonic acid had sprung up very, very high. All of my omega-6s, you can see, were really high. It didn't take much. I only do this annually, but it was, in 2019, you can see my arachidonic acid was down to a reasonable amount. Now, it looks like the arachidonic acid is moving towards low, but arguably, I think that's sufficient for me to generate adequate inflammation when inflammation is needed, such as in acute infection. All right, so let's talk a little bit about arachidonic acid and some of those derivative molecules that are so important in inflammation. The lipid membrane is where where all our fatty acids are housed. Arachidonic acid cascade occurs when phospholipase A2 is upregulated. It's an acute phase reaction protein. So you'll see, and inflammation will perpetuate this cycle. You'll see PLA2 increase in reaction to various cytokines and just in reaction to mechanical stress, emotional stress, physiologic stress. So it's right there in the membrane, ready to cleave arachidonic acid to be funneled down into eicosanoid production. Depending on the enzyme that acts on it, be it COX-1 or 2 or any of the lipoxygenase enzymes, will dictate the eicosanoid products produced. So the more arachidonic acid we have in the membrane, the more readily it will enter into this pathway, say, as opposed to an anti-inflammatory pathway pushed by the omega-3 fatty acids. And here's an example of the two fatty acids that I've boxed here. EPA, or eicosapentaenoic number 2, relative to arachidonic acid. There's just quite a bit of arachidonic acid in circulation in the membranes in the body, and you can see here comparing these two 20 carbon length eicosanoids. Arachidonic acid on a good day generally dwarfs EPA. Just taking a little closer look at arachidonic acid, we can make non-enzymatically produced and very toxic isoprostanes. So these are an oxidative byproduct of arachidonic acid, isoprostanes, and we can measure them. Actually, they're in standard laboratories as a marker of oxidative damage. But lipoxins, part of the inflammation resolution, can also be produced and are essential to quenching the inflammatory cascade. So getting up close and personal with the arachidonic acid cascade, we can see again that the prostaglandins are produced via COX-1 or COX-2. These are, without question, some of the most potent initiators of inflammation in the body. In fact, they're fundamental, really arguably, as I said earlier, to all inflammation in the body, regardless of pathway or mechanism. There's, generally speaking, some arachidonic acid eicosanoid derivative molecule involved, or multiple involved. So prostaglandins are potently inflammatory, and the lipoxygenase-derived leukotrienes are also potently inflammatory. But and actually, let me just mention too, F2 isoprostanes, these are non-enzymatically produced compounds. They're produced under oxidative stress, so they're a byproduct of oxidation. These guys are damaging in their own right, and we use these to evaluate for lipid peroxidation. I mean, they can be useful, and you can actually measure F2 isoprostane at most standard reference labs and get insurance coverage in them, just as an aside that's That's what we found in our practice. Over on the right-hand side here, lipoxins, again, these are the anti-inflammatory arachidonic acid compounds. These guys come into the picture after the inflammatory event has occurred, and they clean up. So we want lipoxins to be produced. We want some arachidonic acid. We've got plenty of it, but we want some to be able to mount an inflammatory response when it's needed, but we want to be able to clean it up right after. In this particular study, this is looking at ulcerative colitis. Individuals with the highest relative concentrations of arachidonic acid have in adipose tissue had a significantly greater risk of developing ulcerative colitis. And their argument was dietary modifications may therefore prevent or reduce incidence of UC. This is an interesting. This was a practice changer for me, actually. So, coming again from COX-2, cyclooxygenase 2 enzyme, arachidonic acid-derived PG prostaglandin E2 is a potent inflammatory mediator. With regard to hormones, PGE2 stimulates upregulation of the enzyme aromatase, which drives testosterone to estrogen. So it aromatizes testosterone and drives it over to estrogen. So in women with a higher estrogen and estrogen-dominant associated conditions, or in men with low testosterone, if inflammation is significant player in pushing that pathway, the movement of testosterone to estrogen via PGE2 upregulated aromatase. What this means for us in terms of addressing these profound estrogen imbalance conditions is that we go back to thinking about omega-6 and omega-3s and dropping omega-6s and increasing omega-3s. That would be step one. So in my toolkit, working with estrogen dominance in my practice, this is a fundamental first step process. And we see, in this study from 2014, in the US, women with a higher ratio of 3 to 6 in serum had a significantly lower risk of developing breast cancer, actually a full 27% reduction in breast cancer risk. And this is just with higher omega-3s. Now, we can go back to this arachidonic acid cascade and also look at our botanicals. So, building up a good anti-inflammatory protocol for not just, looking at aromatase or estrogen dominant conditions, but for really looking at inflammation in general, which underscores, all of or most of the chronic conditions we're working with. We can focus in on the various botanical interventions and where they act in the different enzymes in the arachidonic acid cascade, and pull together, along with adjusting diet and increasing omega-3 supplementation, a good protocol that will form the basis for, I think, interventions for many different conditions. And here is a table looking at some of those botanicals with dosing and indication. So, and again, chronic inflammation is playing a role in most conditions. Omega-3 fatty acids are pleiotropic in their actions. That is, they do a lot of stuff all over the place. And I just wanted to show you using this figure. It's a little bit complex and kind of messy, but I think it makes the point. So in the upper left corner, we're looking at an aspect of the lipid membrane called the lipid raft. This is like the bridges to the enterprise is the lipid raft to the overall lipid membrane. So yes, we're thinking about changing the ratio in the lipid membrane to having more omega-3s, but specifically, we're wanting to change the structure of the lipid raft. Now, in the lipid raft sits the toll-like receptors. I know Dr. Roundtree spoke about TLR4 and its role in driving inflammation, an upregulation of tumor necrosis factor B. The T cell receptors are there, and this is where the PAMPs and DAMPs bind and turn on a potent inflammatory cascade. We can, just by changing the ratio in the membrane and increasing omega-3s, we can we can change sort of the binding affinity of the PAMPs and DAMPs, of the inflammatory compounds, to these receptors. And by doing so, we slow down, we can inhibit NF-kappa B translocating into the nucleus and turning on all of the cytokines. So this is step one in sort of the wonderment of omega-3s. Omega-3s will also enter the cytosol through various transport proteins, and once here, they will make their derivative molecules. They make collection, a broad collection of resolvins. They also make eicosanoids themselves. So they make a number of different, well, hundreds of derivative molecules that are anti-inflammatory in their effect. They can inhibit directly the pro-inflammatory eicosanoids produced by arachidonic acid. They can also inhibit by moving PPAR over here across again into the nucleus. They can inhibit NF-kappa B, via multiple mechanisms. It's actually really quite extraordinary, the breadth of the actions of omega-3 fatty acids. So I mentioned this at the beginning of the presentation. This is an interesting study showing that a good dose of EPA and DHA together was as effective as Humira in pain reduction. I want to point out that it took 3 months. So taking omega-3s isn't, here, take 2 and call me in the morning. We need to be consistent with it, and it requires a therapeutic dose. So I think this is a good study for a number of reasons, particularly showing the dose and the duration to achieve efficacy. This study also showed that there was a 47% reduction in pharmaceutical use with fish oil versus 15% in the placebo. And early intervention with EPA and DHA was associated with a higher rate of remission and a lower use of NSAIDs. With EPA and DHA, only 22% needed NSAIDs, without a full 77% needed NSAIDs. And again, this is looking at rheumatoid arthritis. This is kind of a neat table. It's looking at inhibition of some of the key pro-inflammatory cytokines, tumor necrosis factor alpha and interleukin-1 beta. You can see the doses of omega-3s used and the extent of inhibition of these two cytokines. These are small studies, mostly were done in healthy individuals. But again, it gives us an idea of therapeutic amounts to exert an anti-inflammatory effect and the extent of the potential of that anti-inflammatory effect. This is a great study looking at reducing IL-17 and tumor necrosis factor alpha in kids with asthma on a reasonable amount. Having a toddler myself, it's going to be challenging getting a sufficient amount of fish oil into her. So this was 180 milligrams of EPA, 120 milligrams of DHA, again for 3 months. So you need to stick with it to achieve therapeutic outcome. And this is in kids with mild to moderate asthma. Pulmonary function tests improved by a whopping 72% in these patients. So just a great outcome with a relatively modest amount. All right, let's look at a case study when I was consulting at the laboratory. I think this is a good teaching case. This is a 54-year-old woman with chronic asthma. Unmanageable times decades. So she's been on bronchodilators, she's been on her share of steroids, she's been managed on leukotriene inhibitors, et cetera, with no benefit, or she requires a cocktail of drugs to keep her asthma sufficiently controlled. Her clinician ordered a fatty acid panel, and you can see that actually at a glance, most of them are low. But when you zero in a little bit more closely, relatively speaking, she's got a lot of arachidonic acid. So she's got maybe 30 times more arachidonic acid in circulation than she does its corollary in the omega-3. So the anti-inflammatory EPA is down at 19 and arachidonic is at 535. So quite a skew there. Mead down here, if you're curious, will rise in patients who've had polyunsaturated deficiency. So she has an overall pretty profound deficiency, but arachidonic is quite high. Lipid peroxidation is a common finding in asthmatics. So this is increased oxidative stress happening.
It's 11 o'clock.
Now, when we're thinking about arachidonic acid in asthmatics, remember that via the lipoxygenase enzyme, the leukotrienes are produced. And the cystenyl leukotrienes, a specific subset of leukotrienes, are the most important class of molecules in asthma pathogenesis. And eosinophils in the inflamed airways of asthmatics have an increased arachidonic acid content up to 10-fold more than peripheral blood of those same patients. So it's the arachidonic acid is just concentrated in the airways. And here they are. Here's the cystenyl leukotrienes, very potent pro-inflammatory mediators. I just want to, just remind you of that botanical chart I showed you earlier, and we listed a number of good botanical interventions that you might consider for this asthmatic, such as Boswellia. That's not what this clinician did. Let me show you what this clinician did. That's just as an aside for the many asthmatic patients I'm sure you're seeing in practice. You can use that chart. This patient, her intervention was actually quite simple. They balanced, fatty acids were balanced, so a good dose of EPA